TopMedTalk.
Hello and welcome to Euro Anesthesia 2023, the annual meeting of the European Society of Anesthesiology and Intensive Care. It's TopMedTalk on the Edwards booth. I'm Desiree Chappell, and I'm joined by Monty, Mythen, my co-host. Hello, Monty.
Desiree, great to see you. Great to be here.
It is day one of Euro Anesthesia. It's fun here in Glasgow.
And I know it's a recurring theme since post-COVID where we say what a buzz there is and how exciting. But actually, I think this is the busiest trade exhibition we've been in the post-COVID period.
It's busy. It is.
Which is great.
Agree. Yes, I know. I love it. There are lots of familiar faces, lots of friends that we're seeing. It's hard to walk just down one row without seeing somebody that you know.
And high level, everyone has made a great effort to give lots of engagement opportunities, I think, is the thing. There's lots of reasons for people to be in here looking at the amazing technology that's on display.
I think that's probably been one of the most exciting things for me is actually getting out and seeing what we could not see for a couple of years, and new technology, new drugs, new conversations.
Not to undermine how brilliant the program is that takes place outside the breaks.
Yeah.
Wonderful lunchtime session today that we were in, like some of your guests you're about to introduce, and I had to walk away from something I wanted to stay in, which was about the microcirculation, a pro-con debate about the microcirculation. Oh my goodness,
yeah, that is something right up your alley. Well, we'll have to dive into that a little bit later. Monty, we've had some great conversations on TopMedTalk today. Numerous. Some we will be putting out tonight. Some we're going to hold on and put out some teasers over the next couple weeks. So do check those out on TopMedTalk.com. We do want to take a minute and thank all of our sponsors, Monty, for helping keep TopMedTalk lights on, free open access to the world.
Absolutely. So, we have a whole raft of sponsors now. We couldn't keep it, as you say, free open access, but a very big shout out, as always, to Edwards. Not only we're at the moment on their booth, we were on the GE Healthcare booth earlier, another great sponsor, but Edwards are our original sponsor. We wouldn't be here today if it wasn't for them bravely sponsoring our first attempt.
Yeah. They took a chance. Podcast was fairly new back in 2017, whenever you started.
Exactly. I've just checked. We've just gone over 1,700 podcasts.
Yeah. And
Not
how
sure
many?
if that was a great idea. We are just, if you just look at the main podcast website, we're just shy of 2 million downloads. I know we keep talking about the 2 million threshold. If you add in the other ones, the other subcategories, we're already over 2 million. But we've got to get that primary one over 2 million. And we're just about there.
I'll say we're on the precipice. It's happening anytime. It might be this podcast that takes us over the edge.
It is. We are very, very close.
Well, without further ado, we wanted to bring in our next guest to continue conversations that we've been having over the years about numerous studies that have come out recently. And here at ESA, we've had some great conversations as well. So happy to welcome back Bernd Saugel. Bernd, it's so wonderful to see you again.
Thank you very much. Thank you for having me. It's a pleasure to be here again and to join you.
Yeah, we were sitting, so recently, over in 2022, we were at ASA, so the American Society of Anesthesiologists in New Orleans. So fun meeting, got to have a good conversation there. And at ESA in Milan, we were started our conversation there where we first met.
Absolutely, and now we're here in Glasgow.
And here we are. So Bernd, when just really briefly, we can talk about this a little bit later. When we met you the first time at ESA in 2022, we were talking a lot about blood pressure and trying to figure out where we should be targeting blood pressures. Any more revelation that you can share with us on that?
Well, as everybody probably knows, in the meantime, POISE 3 was published a couple of weeks ago.
Yeah.
So a hypotension avoidance strategy versus an hypertension avoidance strategy with an outcome of cardiovascular complications. And basically the intraoperative management consisted of maintaining mean arterial pressure of around about 60 versus around about 80. So two different fixed blood pressure targets and no difference in the primary outcome. Not clinically important difference, no statistically significant important difference. So, but this trial shouldn't be misinterpreted. Does not mean that hypotension is not important, because of course nobody was randomized to hypotension. There was very little hypotension. And as I always said, I still think that the blood pressure target should not be fixed, but personalized and individualized to each individual patient. And this is why I'm happy to announce that we already started our IMPROVE trial, a large German multicentre trial in 16 centres, including more than 1,300 patients, and testing the hypothesis that personalized blood pressure management based on ambulatory preoperative monitoring compared to routine care, which usually is 65 millimeters of mercury at the lower intervention threshold, improves postoperative outcomes in patients having major surgery. We included the first over 100 patients. 2 centers already actively recruiting, and all the other 14 going to join the next couple of weeks. So we are very proud that we got that trial running, and I'm very, very excited about the results that we will probably have in around about 2 years.
Wow, you've been busy, Bernd. Congratulations on that. Well, good. Well, so questions still not answered, but it sounds like we're moving in a direction where we may have more information. So that's...
Yeah, we still don't know the magic number for each individual patient, but I still at the moment would say maintain mean arterial pressure above 65. There is no evidence that you should universally target higher pressures, and what we do with patients who have chronic arterial hypertension, we will probably know more about with the IMPROVE trial.
Yeah.
And we're not going to go into all of the detail of what we recorded you about last time, about recording the ambulatory blood pressure properly and getting a real target, and nighttime blood pressures and nocturnal dippers. So we'll put it in the show notes to link to all those other great conversations. But we've got 2 studies to discuss in greater detail today. One of them published relatively recently that we discussed at our lunchtime session and beyond that.
Yep.
And another one which is literally published, let's call it today, in the last 24 hours. So let's take those sequentially, Desiree.
Yeah, so we're just going to start with DETECT.
No, it's
the first one.
Yeah.
Okay. Well, first, before we dive in that, I do want to introduce our next guest who's sitting here so patiently, but a friend of ours, Thomas Scheeren. Thomas, it's so wonderful to see you.
Thank you very much. Thank you for having me. This time in a new role, because I changed after 30 years of being a clinician and working in the field as an anesthetist and intensivist. I changed roles last year, joining Edwards Lifesciences, the company we are at the booth at right now, which is dedicated to patient safety and hemodynamic monitoring. And it was quite an interesting step, and I'm happy about my new role. And so first time after all these years in a new role at Euros Anesthesia.
Oh, yeah, that's true. Well, congratulations. I'm sure it's been an interesting transition, but this has been kind of your life's work anyway, yeah? So
yes, it is. So it was a logical transition for me. And as I said, I enjoy it very much.
Good.
To work with great clinicians like Bernd, no longer competing, but collaborating, and this is...
we never competed, we collaborated and were friends.
Okay.
Absolutely.
Thanks.
And we have numerous wonderful interviews with Thomas over the years as well.
Yeah, absolutely. On TopMedTalk, you can see all those. Again, we'll link out. So, gentlemen, you've talked a little bit today about HYPROTECT, and that's what we want to dive into next. So, Bernd, tell us a little bit about that study.
So we will start with HYPROTECT or speak about the other trials that we spoke about in the lunch symposium?
So I would go for the EU HYPROTECT first, because that's been published relatively recently.
Very good.
And then we'll talk about the one that was published in the last 24
Perfect.
hours.
Very good. So we start with EU HYPROTECT. Yeah, that was an interesting study. It was a European multicentre prospective observational registry in patients having major non-cardiac surgery. So it was a large observational study that we started in 2021. And the aim of the study was to investigate the incidence, duration, and severity of intraoperative hypotension when you use predictive monitoring that is supposed to predict hypotension from an advanced analysis of the arterial blood pressure waveform.
Wonderful. And what was the primary outcome that you were looking at again?
The primary outcome is hypotension. So our hypothesis was that the incidence, duration, and severity will be low when you use predictive monitoring.
Okay. And Monty, you can jump in because you're much better at diving into this.
I mean, let's call us the academic snobs.
Yeah.
Are going to immediately say, It's not a large multicentre, pragmatic, randomized, controlled trial. But then you say, well, hang on a second. We've actually got enough reference data about hypotension. We can come to your own data in a second, Desiree, that everybody who's looked seems to has consistently found a large amount of intraoperative hypotension.
True.
So at some stage, you sort of have to turn around and say, before we get to any alternative trial design or interventions or variability, let's do some robust evaluation to see if we just reduce the incidence of that a lot.
Yeah.
Now, to put it in context, you and your group has relatively recently reported on the incidence of IOH using a measure in the United States of America, which is an approved quality measure.
It is.
Which is a cumulative 15 minutes, 15 minutes of hypotension below a threshold of 65.
Yeah.
And tell us the result.
Yeah, so we partnered with another large anesthesia group. So I'm Vice President of Clinical Quality for North Star Anesthesia, large national anesthesia group in the U.S., almost 3,000 providers. Partnered with U.S. Anesthesia Partners, another large anesthesia group, and we looked at 127,000 patients. And for a mean less than 65 for greater than 15 minutes, in that 127,000 patients, we saw 29% hypotension for those patients.
And that was, and we'll come back to when we talk about the second study we're going to talk about. It was more common, if anything, in lower risk patients.
Lower risk patients, around 2 to 3 hours. We actually saw a large population or a large percentage of hypotension in our ASCs, ambulatory surgery centers.
So certainly in most people's experience, hypotension is commonly available. And we're going to talk about the time-weighted average. So we want to give that some context. The time-weighted average is looking at, let's call it the area under the curve of the burden of hypotension adjusted for time.
Yes.
Because obviously the longer a case goes on for, the greater the opportunity to be hypotensive. Do you have the number for the time-weighted average? Because you want to put the results from this study in context.
Yeah.
What was your TWA time-weighted average?
The whole 127,000 patients, our time-weighted average was 0.67 millimeters of mercury.
Which doesn't sound very much, but to put it in context, the reference point we're going to refer to is 0.67.
Yes.
Yeah, okay. Bernd, what was the time-weighted average for your study, which is different in a number of ways, but the severity of the patients, if anything, is more severe patients. What was your time-weighted average? Because this number doesn't make a sense to a lot of people, but we put it in context. Yours is about 0.7 for argument's sake. Yours was...
I don't tell you yet. I tell you a little bit about the study before that. So, to keep the tension up.
Hang on, keep the tension up. But what we have is a reference point of 0.7.
Yes, we'll come back to us.
So tell us about the remember the 0.6. Yeah. So first of all, I think I would disagree with you because regarding the trial design, at least it was large.
Yes,
so I agree that it was not a randomized control trial.
I was being provocative about this one, so I think it's a great trial.
So it was not a randomized control trial, I agree. So it was an observational registry, kind of reflecting what happens in the real world in the operating rooms. But, and this is the advantage of this study design, it enabled us to include a lot of patients in a short period of time. So we included 749 patients, so it is large. And we included adults having non-cardiac surgery, major non-cardiac surgery defined as an expected duration of surgery of more than 120 minutes. And all of those had intra-arterial blood pressure monitoring and on top of this, predictive monitoring with this HPI technology. We didn't include patients having emergency surgery. We didn't include patients having atrial fibrillation, but besides of this, or a couple of other exclusion criteria, we included a broad range of patients having a broad range of major inpatient surgeries. And all of those patients had intra-arterial blood pressure monitoring, had their predictive monitoring in place. The primary endpoint was the time-weighted average. Again, this is the area under a blood pressure threshold. This was 65 in our study, as in many other studies, and this was normalized or divided by the duration of monitoring, simply because the monitoring time, which usually is the same as the duration of surgery, of course differs among different patients. And we had a couple of secondary endpoints that we may talk about, but for the primary endpoint, and now you can repeat your the reference that you observed in your study.
0.7. 0.7.
Okay.
We'll go with that.
The median time-weighted average mean arterial pressure below 65 in the HYPROTECT registry was 0.03 millimeters of mercury. And the interquartile range was 0 to 0.2.
Wow. Impressive.
So this is substantially lower than in that reference that you gave us.
Yeah.
How can you explain that, Bernd? Or what is your interpretation? Why did you find such a low incidence?
Well, now the trial design comes into play again, or the study design, of course. So with these results, we cannot claim that using predictive monitoring causes that there is basically no hypotension. But what we can say is that in this real-world registry, more than 700 patients, in centers who used predictive monitoring before, so all of those centers and clinicians working there were experienced with using the technology. When you give that technology to clinicians who are able to use it, obviously there is very little hypotension. This may be confounded by other factors. Maybe they are very interested in hemodynamics. Maybe they are very well aware of the association between hypotension and outcomes.
Yeah.
This is something that we could only answer when we, if we would have done a randomized trial. But what we take from this is that in this real-world evidence registry, the amount of hypotension was very, very low when patients had predictive monitoring treated by clinicians who were experienced with this type of monitoring.
So can we put it in other words? Or would you agree when I say, in the hand of experienced users, the HPI technology can almost eliminate hypertension because 0.03 is close to zero. So there is very little or almost no hypertension. Would you agree with that?
I would not claim that there is a causal relation between the monitoring and the primary endpoint of the time-weighted average of hypotension. I would be descriptive here as a researcher, and I would say, given that study design, in this real-world evidence, in the hands of experienced clinicians, patients who had monitoring with this predictive technology and who were treated by those clinicians, they had very, very little hypotension during surgery.
And what evidence would you need to make that statement, that causal relationship between the monitoring and the reduction of hypertension?
If you don't just want to look for an association or just be descriptive, as I try to be now, you would still need some kind of a randomized trial. It may be a randomized trial randomizing individual patients. It could also be a randomized trial like a cluster randomized trial, crossover trial, where you use monitoring for 3 months and don't use it for the another 3 months and go back and forth between those two clusters. But you would need to have a comparison group that is not monitored with the HPI, and if you can then show that there is a difference, then you may assume that there is a causal relation.
And we just literally finished interviewing Joyce Young, who had a paper co-published with Paul Miles, etc. today. Joyce being one of the leaders in the United Kingdom in clinical research, the head of the clinical trials network there, the National Institute of Academic Anesthesia. This concept of adaptive platform trials, because this was done quickly, because it's a real-world evidence, non-RCT, with a lot of endeavour and a lot of information out of it. But the classical pragmatic RCT, to address the question, has typically taken very many years.
And it's very expensive.
Very, very expensive. So can we find a middle ground there? Do we think the possibility is there with the adaptive platform, Bayesian analysis, making interim analyses and adapting, that we can accelerate this whole process?
Well, those new study and trial designs are fascinating, of course. We've seen that during the COVID pandemic, that you can include a huge amount of patients with this adaptive trial designs, you can answer numerous different questions in one patient population. You can, as soon as you know that one treatment works or doesn't work, you can switch to the next one. So in theory, that would also be possible for a monitoring and treatment management strategy like this one. I agree with you that a classic randomized control trial takes time, is expensive, enrollment rates are usually low. And just to give you an impression here for this registry, for this real-world evidence, it took us only 9 months to include all of those patients.
Yeah.
And from the first patient in to the publication of the paper, it was around about 18 months. This is something I spoke about our randomized trial before, so it will take us at least 1.5 years to include those 1,300 patients.
Yep.
And here we were very quickly because we had motivated centers on board, but still it was an international study, 5 European countries, and still we were able to get all the contracting and all the stuff done and include the patients. So it was a good example that we are able to include patients quickly when we work together in a collaborative network.
Oh, absolutely. Thomas, did you have a question?
Yeah. If you compare that with a RCT that is just finished, and Monty, you were involved in that. I'm talking about the Optimized 2. How long did that take from the planning inclusion?
5+ years into the whole thing.
Exactly.
But now that was disrupted by COVID. But even despite that, once you have complex interventions in complex patients, and the other challenges, because they're incredibly expensive to do, you tend to reduce your number, even though that's going to be 2,000 plus patients.
Yeah.
You tend to sort of go for not necessarily the upper limit of the confidence intervals, which might give you 10,000 patients. You say, well, I hope we're okay with 2,500. The other advantage of adaptive platforms is the same rigor is in there, but at least you have a chance to adapt.
True.
Which is, it's a long way to go all the way to the 2,000 plus patients and then open the parcel, to open the envelope. When you could say, oh man, if we'd only done this, if we'd only done that. So.
I'm sorry to interrupt, but I have a lot of questions because this is definitely something that I'm actually dipping my toe in a little bit. Our organization and one of our facilities, we are enthusiasts for HPI and advanced hemodynamic monitoring, really. And so, when we've looked at it and we're, doing interventions or starting to use it, we are very enthusiastic and follow protocol. In HYPROTECT, did you actually have a protocol that you used, or was just people who knew how to use the monitor and they used it to avoid hypotension?
There was no study-related protocol, but because clinicians working in those centers were experienced with using the technology, I assume that they were also familiar with a secondary screen, which gives you an idea of the underlying root cause of hypotension. And I would assume that hypotension in patients in this registry was treated more causally, more by the root cause than in other studies or trials, where when you have a blood pressure target, clinicians tend to simply use a vasopressor to increase the number on the screen. So I would assume, but this is nothing that we can prove, that in that registry, patients were treated or had causal treatment for intraoperative hypertension simply because as part of the predictive monitoring screen, you have the secondary screen suggesting you potential reasons and causes for hypertension.
I can add on that because we did ask the centers retrospectively when the study was done, did you use a protocol, and if so, which kind of protocol? And as far as I remember, 8 of the centers did use a goal-directed therapy protocol, if you will, and 4 centers used actually an HPI-specific protocol. So they did use a protocol, but the protocol differed between hospital to hospital.
But could you get a sense as to whether the fundamentals were the same? In other words, address, preload,
exactly,
contractility, afterload.
Most
protocols had volume optimization as the first step, and then looking into other causes.
Because to give that some context, you do report in the paper roughly how much fluid was given.
That's what I was going to ask.
What type of drugs were given. And, we had I've obviously read it in detail. We had another look earlier today. The amount of fluid that was given is sort of in line with the moderately liberal message. It didn't look restrictive. It looked moderately liberal. And the use of vasoactive agents was, which, we've talked about, the phenylephrine pandemic. Where you see phenylephrine infusions being run to maintain blood pressure, and these large reports of no fluid and a phenylephrine infusion. as I remember, phenylephrine was relatively infrequently used compared to other vasoactive agents, and almost all the other vasoactive agents had some beta activity as well. So there's a lot of nuance in there to have a look at.
That is true, and that is specifically interesting because it's a European trial. You know, it was 5 different European countries, and I know from my own experience that when you travel to different countries, routine care is quite different. You know, we always compare our interventions to routine care, but routine care varies substantially between different centers and even between different clinicians within centers. For example, in our institution, norepinephrine is the first-line vasopressor that we basically use in every patient, but I know that in the US it's different, and in different European countries it's different. And therefore, the HYPROTECT database will be a very, very valuable source to look deeper into those issues, how hypotension was treated.
And even the availability of drugs differs between countries.
Oh, for sure.
In many countries, phenylephrine that you mentioned is not available. In Europe, on the opposite, we have other, for example, in Germany, we have this combined Acrinor thing that is not available in other countries. So there
was one in there that sounded like a caffeine substitute.
Exactly.
What's
That's
that one?
the one I mean.
Okay.
So, well, what I thought was really interesting, too, is that, 95% of patients actually did receive a, quote, vasopressor? Is that right? Or
a vasoactive agent.
A vasoactive agent, yes.
I mean, the other trials like Optimize 1, for example, which collected the detail in great detail from patients, you usually find 98 to 100% of patients get a bit of something.
Yeah.
So I don't think that's right. So was it about 95% got something? So
I don't really remember, but it may be around this. Yeah, but this is something that we see in many of our own trials too. So, for example, in trials that we do at our institution, like 100% of the patients literally have norepinephrine because it's simply we prepare it even before induction of anesthesia. Like every patient has norepinephrine.
Yeah.
But
what I thought was interesting, I'm sorry to interrupt, but to talk over you, but what from my lens in the U.S., most people will say, "Oh, well, they just put neosynephrine on, so I'm doing the right thing. I put it on everybody." Where that may not actually be the answer. I mean, we don't use norepi very often in the U.S. Low dose, hardly at all, unless you're in a cardiac center working with hearts. So, sometimes I get a little bit nervous about statements
it's finding
like
the
that.
right balance, between hypotension, which is associated with organ injury. We need to find the balance between the dose of vasopressor, the amount of fluid, and you need to identify those patients who benefit from an inotrope. So it's myocardial depression is one major cause of hypotension, and we shouldn't forget about this. Despite all the literature on blood pressure during the last decade, we should keep in mind that blood flow and blood pressure are related, and that we need to treat all of those different cardiovascular components. And that we, during every single episode of hypotension, need to think, does my patient need volume,
what is the
inotrope?
cause? Yeah.
So we want to go on to the next study in a second, but executive summary, the closeout, when you compared it with other studies in the space, you had by far the lowest amount of hypotension. You had the least hypotension by a long way compared to other comparators in this space, including RCTs of using HPI. And it's difficult, but your outcomes look pretty good. So I mean that's always tricky. But if you look at your acute kidney injury rate, for example, and compare it to other published studies in this space, you've got the lowest acute kidney injury rate. Now we have to be careful with association, causation, etc., etc. But that certainly sets us up to say this is a journey that we're on. Mm-hmm. This is a journey we should be traveling. We've got some important variables in there, like the amount of fluid and the choice of norepinephrine, etc., etc. But I want us to jump to, if that's okay.
Yeah.
Do you disagree with any of that?
Absolutely.
Is that fair?
I agree with that. Yeah, I think the amount of hypotension is impressively low.
Yeah.
No.
We started looking at the control groups of the randomized trials on the HPI because we wanted to have a comparison, and then we noticed that we even can start looking at the intervention groups in the previous randomized control trials, and the amount of hypotension was substantially lower even compared to those intervention groups. About the reasons, we discussed this before, but I agree it was very low, and the rate of acute kidney injury is around about 9%. is lower as that described in many other studies, but here we would need a propensity matched analysis to really make the claim that the rate of AKI was lower than in other studies or trials.
Fair.
So in the interest of time, if that's all right with you, we should jump to the hottest news.
Hot, off the press. Oh.
Which is?
The DETECT trial. We spoke about the DETECT trial before, but it was now co-published for that Euroanesthesia conference. So it was accepted in anesthesiology, and we spoke with the interim editors-in-chief, and we were able to get that published just now during that conference to be able to show those results and to simultaneously publish it in anesthesiology. Okay. So the DETECT trial was a trial to test the hypothesis that continuous finger cuff monitoring compared to intermittent oscillometric monitoring reduces hypotension both during the induction of general anesthesia and during surgery in patients having major non-cardiac surgery. So there were two hierarchical primary endpoints. One was the area under minute pressure of 65 during induction, and the second one was the time-weighted average. So again, the area normalized for the monitoring time during surgery. And we randomized 242 patients. All of those patients had continuous finger cuff monitoring, so they were randomized to either unblinded finger cuff monitoring or to intermittent oscillometric monitoring with blinded finger cuff monitoring. And the results are just published now, and during both periods, so during the induction period and during surgery, patients assigned to continuous finger cuff monitoring had substantially less hypotension duration and severity compared to patients who were assigned to intermittent oscillometric monitoring, bringing us to the conclusion that continuous monitoring reduces hypotension or helps clinicians reduce hypotension. And we need larger randomized trials to see whether this also translates into benefits improvement in outcomes. But in the meantime, I would say that we as clinicians should consider using continuous monitoring instead of intermittent monitoring in patients having non-cardiac surgery, both during induction and during surgery. And you need to decide whether you need an arterial catheter or whether you can use a finger cuff.
Yeah. So I want to back up for just a second and talk about the finger cuff technology, because I don't know if a lot of people understand exactly how that works and how that's different than a blood pressure cuff.
Yeah, well, the blood pressure cuff, the basic measurement principle is oscillometry. So you have an occluding upper arm cuff that you wrap around an extremity, usually the upper arm. And this, by definition, gives you blood pressure in an intermittent way. So you can cycle the measurement, of course, like every 2.5 minutes. Usually it's done every 5 minutes. So that is what in the US guidelines, it tells you that blood pressure should be measured at least every 5 minutes. It doesn't make sense to do it like every 30 seconds because the measurement per se can kind of influence the measurement.
And it's very hard to do it that
You
quickly.
can't really do that.
Absolutely.
Especially if you have changing.
So those of us who have higher blood pressures may have one at home that we're encouraged to use on a regular basis.
True.
You hit the button.
Yeah.
You're a bit disappointed your blood pressure's higher than you expected it to be because it hurts when it goes up the first time.
True.
And then you hit it again, and now already a few minutes have passed, and then you don't like the second one.
Yeah.
So you hit it a third time. Does that happen in clinical practice as well? Or?
Well, of course, but the other way around, it's often you don't believe that there is hypotension. So you have an oscillometric measurement and it's low, then you repeat the measurement and you can lose a couple of minutes just trying to confirm your measurement.
Or you don't get a measurement at all. If you going into hypotensive state or something like that, so maybe 10 minutes before you actually have a blood pressure, right?
That is true, but even if it works perfectly well, then you usually have a blood pressure like every 3 or 5 minutes.
Yeah.
And well, the finger cuff the main difference is that it provides blood pressure continuously.
Yeah.
So those finger cuff technologies are also called vascular unloading technology or volume clamp method, and the basic principle is that you have a finger cuff that has an integrated infrared light source and detector, and this can measure the blood volume that is in the finger arteries. And then this finger cuff adapts its pressure very high frequently and tries to keep the blood volume in the finger arteries constant throughout the cardiac cycle, where it would change all the time. And from the pressure that is needed to keep the blood volume constant, you can indirectly derive a continuous, non-invasive arterial blood pressure waveform that you hardly can distinguish from a waveform that you record with an arterial catheter.
Yeah. And so were there any limitations? I mean, personally, I've used this, so I know there's some times where it's not absolutely 100% perfect. Blood pressure cuffs on the arm are not either. What are some of the limitations that we have to worry about when you use a finger cuff and that you experienced in the study?
In the study, the number of patients in whom the measurement was not possible was very low, but in general, of course, the system requires intact finger perfusion. So that is a clear prerequisite for the measurement. So you shouldn't do it in patients in septic shock in the ICU on high doses of vasopressors or patients with severe cardiovascular morbidity, but those are not the patients who are the target population for that kind of monitoring, because in those patients you would use an arterial catheter anyway. So we studied this in another trial. In the AWAKE trial, we showed that continuous intraarterial monitoring is able to reduce hypotension compared to intermittent. But here we focused on patients who were supposed to have oscillometric intermittent monitoring. So this is intermediate risk patients. And in those patients, the feasibility of the measurement was good. So we could measure in the very, very little patients where the measurement really was not possible. And I think it's, the strategy behind those finger cuff methods should be to kind of replace the intermittent upper arm cuff and not to find niche indications where you could use it in patients who now have an arterial catheter. So I'm still a believer in the arterial catheter. Yeah. And I think that the finger cuff should replace the intermittent upper arm cuff.
Yeah. Personally, I have started to use it so much more on cases where, we have a large obese population that we take care of in our facility. We're tucking their arms. It's very tough to get a blood pressure cuff when you have a surgeon leaning on it. I put a finger cuff on all those patients, or someone that I'm kind of like on the fence where I probably don't need an arterial line, but it would be nice to have a continuous blood pressure line. And it has saved, again, all anecdotal, my experience, but it has saved me many times to have that.
With the Edwards technology, all the other variables are available.
Then that's true.
Cardiac
so you
output,
have everything.
Stroke volume, SVR, DPDT, EA dyno, and so on. Yeah. Because you've now got an arterial waveform, you can have the whole lot. Yeah. Is that right?
Yeah. And it's, so many, and being in a quality role and looking at the large the larger perspective of adverse outcomes because of issues with monitoring and technology and not necessarily having continuous blood pressure. This is very, enlightening to me to see this, because if we could have continuous blood pressure that was accurate, reliable, that would be, wonderful to have. So.
I have a question to Bernd, because you showed a study earlier this day in our symposium about the reliability of the upper arm cuff, which is still used in 95% of the cases, let's say. And I'm not sure if clinicians, this study is more than 10 years old that you showed, and I'm not sure if clinicians are aware of that. What you were showing is that this study showed, if you compare these measurements to the gold standard being intra-arterial measurement, that you underestimate high blood pressures and you overestimate low blood pressures, which is quite dangerous. How can it be that this important results, and it was not a small study, are not aware in our community?
Well, confidence in measurement systems is a complicated issue, and sometimes the method that is around for the longest is considered the most reliable, so everybody is just used to it. And the study you are referring to is indeed, it's more than 10 years old, and it's a retrospective method comparison study in more than 15,000 patients having surgery, and they compared intra-arterial measurements with an arterial catheter to the simultaneously oscillometric ones, and they show that there's the risk of substantially overestimating low pressures. And this is something that you can see in clinical practice basically every day, because everybody has seen the situation that you place an arterial or someone places an arterial catheter, you induce anesthesia, and then the blood pressure on the monitor from the arterial catheter that you just inserted is very low. And people won't believe it, and they say, okay, I'm gonna check this and I will do an oscillometric measurement. And then let's say the mean arterial pressure from the arterial catheter is 35, and from the oscillometric cuff it is 55, and then people feel reassured that there's no hypotension, and this is not true.
Right.
The real blood pressure from the arterial catheter that you just inserted is 35, and you just overestimated with your oscillometric measurement.
We're getting the flashing red lights.
Oh, is it time?
Yeah.
All right. Well, anything else, Thomas, Monty, that we need to
Not at the
cover
moment.
on those?
We could talk for hours about this.
I know. Every time we
will.
Interesting topic and relevant for patient care.
Yeah,
patient
absolutely.
Safety.
Patient safety. I mean, that's what I keep.
Do we have the time for 20 more seconds?
Do it.
Yeah.
Because when we speak about oscillometric measurements, what we always forget, and I don't mention it because it means diving very, very deep into this technology, we don't even know what those systems do, because the algorithms are usually proprietary. So if we say we compare oscillometric to anything, we basically don't know what oscillometry is. So you would really need to say, we used this type of monitor with this type of cuff and this software version, and then we could make a claim that it's good or it's bad. So it's a black box. We don't even know what those monitors do.
It's a blacker box, isn't it?
It's so interesting. If you look at the mean that is on the blood pressure cuff versus what's on any other technology.
It's all exactly.
We'll
do that
crazy.
next time.
We will. All right, Bernd.
Excellent.
It's wonderful to talk to you.
Thank you so much.
Thank you so much. Thomas, thanks for joining us today.
Thanks, it was my pleasure.
And thank you for joining TopMed Talk here at Euro Anesthesia 2023. It's been a pleasure, gentlemen. Enjoy the rest of your day. Enjoy the rest of your time here at the meeting, and we'll talk to you soon. Cheers.
Thank you. Thank you for having us.
Thank you. Bye-bye.
TopMed Talk. Thanks for downloading TopMed Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMed Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.